Well, welcome to Medicine Grand Rounds. I'm David Guido. I'm the Division Director of Pulmonary, Allergy, Critical Care, and Sleep Medicine. It's my great pleasure to have two of our interventional pulmonary faculty presenting today. Interventional pulmonary is a relatively new subspecialty within pulmonary medicine, and we're very excited to have one of the premier programs in the United States right here at Emory. Our two speakers will be combining to share a really exciting topic with us. First will be Keriann Van Nostrand. Keriann did her IP fellowship here at Emory when we had a fellowship. We still have a fellowship. After we started our fellowship, Keriann was one of the really great fellows in our program. And we were delighted when she decided not to return to her Jersey roots or any place up north, but stayed in Atlanta. Has been an amazing faculty member in our interventional pulmonary program. And then she'll be followed by David Berkowitz, who was a pulmonary and critical care fellow here at Emory a number of years ago, and then did his IP training at Beth Israel before we had an IP fellowship. And then he's been instrumental in building our IP fellowship over the last decade into one of the real premier training sites in the United States. So I'm delighted to have both of them here, and Keriann, you'll be going first.
Thank you, David. Thanks, everybody, for coming. So before we can get to the management of bronchoscopic lung volume reduction, we're going to start with an overview of COPD, where we've been and where we're going. So we're going to review both medical and non-medical managements for COPD, talking about surgical procedures related to end-stage COPD or lung volume reduction, review bronchoscopic LVRS as well as its literature, and identify patients that are appropriate for referral. So let's start with learning about what COPD is. And I know some of this may be a little basic, but let's all be on the same page. So COPD is a group of preventable diseases that affect airflow obstruction. COPD is very prevalent. 16 million people in the U.S. are diagnosed with COPD, and this may be an underestimate, as patients often underreport being diagnosed, as well as physicians often underdiagnose COPD. COPD is considered preventable because of its association with tobacco abuse. It's important to remember that some patients with genetic predisposition, as well as recurrent respiratory infections, can also develop COPD. COPD causes symptoms, and that's related to airway inflammation and injury within the alveoli and losing the number of alveoli, as well as the inflammation that impacts airflow obstruction. We diagnose COPD by spirometry with an FEV1 to FVC ratio less than 0.7. COPD is assessed in the clinic, but also in the hospital. And it's complex because our patients, even though COPD affects the lungs, it has systemic effects and manifestations as well. And we need to assess these when we see our patients. Interestingly, the severity of obstruction does not always correlate with symptoms. And because of this, this has influenced the most recent GOLD criteria, which includes not only the severity of the obstruction, but also the patient characteristics of breathlessness and their overall assessment, as well as their exacerbations. And in using these two schematics, we can determine management strategies for our patients with COPD. COPD management can include all of these things or some of these things. For the purpose of this talk and time, we're going to focus on these. We'll start with smoking cessation. And smoking cessation can have the greatest impact in COPD natural progression history. It's important to note that even spending 3 minutes with a patient can influence quit rates. So 3 minutes of our time, we can improve those quit rates. In addition to smoking cessation, we have medications that can be used. These medications don't change the natural progression of COPD. They're focused on improving symptoms, and because COPD is not curable. So we're improving symptoms and how our patients feel. There's not a conclusive clinical trial that any medications modify that long-term decline in lung function. With that said, there's a wide variety of medications that can be used. In fact, it feels a little bit like alphabet soup from time to time. All of the inhalers are based on 5 classes of medications, and those are our short and long-acting beta agonists, our short and long-acting anticholinergics, as well as inhaled steroids. And more, we're finding that combination therapies are being put together within inhalers. And that combination therapy is because we found that putting 2 medications together is more effective than the individual components. Also important to note when we're using those inhaled corticosteroids that they have been associated with pneumonias in patients with severe obstruction. Also, triple therapy has been coming out, and while we do think it improves lung function and health status, the jury is still out on long-term impacts. While we can prescribe inhalers, and lots of us in this room do, it's important to note that patient compliance and ability to actually use the medication affects the overall success of these medications. Most patients don't actually know how to use their inhalers, so a good portion of visits for COPD patients are spent on inhaler technique. In addition to medications, we also prescribe pulmonary rehab, and this is where we focus on exercise, education, and self-management. Interestingly to note, this is the most effective therapeutic strategy we have to improve shortness of breath, health status, and exercise tolerance. And this spans all grades of COPD. In addition to pulmonary rehab, we also have oxygen therapy. So oxygen therapy, or long-term, greater than 15 hours, has been shown to decrease mortality in those with resting hypoxia, where there is no benefit for oxygen therapy in those that do not have resting hypoxia. When we think of medical management, we think of those kind of 4 basic things that we spoke about. So smoking cessation, inhalers, pulmonary rehab, and oxygen. There are other options for COPD, which include surgical management, and those are lung volume reduction, bolectomy, and even lung transplant. For our talk, we're going to be focusing on lung volume reduction surgery. So what is lung volume reduction surgery? This is a surgical procedure where we remove the most diseased portions of the lungs with the goal of improving respiratory mechanics. So that includes the ability of the diaphragm and the intercostal muscles to work, but also allows a more residual normal lung to stay, improving overall flow rates as well and reducing exacerbations. This overall theory of lung volume reduction was put to the test and investigated in what we call the NET trial, or the National Emphysema Treatment Trial. And this was a randomized controlled trial which included 17 clinics across the country, and they investigated patients with severe emphysema who underwent either lung volume reduction surgery or medical management. These patients had to have an FEV1 less than 45% and evidence of hyperinflation on their lung volumes. What's interesting, and I won't read this whole slide to you, is that the exclusion criteria is very extensive. One of the things to note on this is the first line, which is patients that had diffuse emphysema were not included in this study. They investigated mortality and exercise capacity on a bicycle, so not just walking, as well as other measures of pulmonary function and respiratory shortness of breath. They characterized their emphysema based on high-resolution CT, and they also determined where it was in the lung, in the top, middle, or lower, and also assessed lung perfusion based on radionucleotide scan. So patients who agreed to be enrolled in the study underwent pulmonary rehab first, and again, pulmonary rehab first. After completing pulmonary rehab, they underwent lung volume reduction surgery or were randomized to medical management. Those who underwent lung volume reduction surgery had this either done by sternotomy or VATS, and the goal was to remove 20 to 35% of the diseased lung. Adherence to the medical treatment as well as smoking cessation was obtained by phone calls and clinic visits. When they did an interim analysis back in 2001, they noticed that patients who were deemed high risk, and high-risk patients were those with FEV1 less than 20%, non-heterogeneous emphysema, and a DLCO less than 20%. These patients had a higher mortality with lung volume reduction surgery, as well as a low probability of having a functional improvement. Therefore, they were no longer included in the trial. So when the trial concluded, they looked at mortality. And I know slides are busy like this, but what's interesting is that at 90 days, across all patients, those who had surgery had a higher mortality than those who had medical therapy. That prompted them to do a subgroup analysis, and the way they divided their subgroups was based on upper lobe predominant emphysema versus non-upper lobe predominant. And when they looked at the upper lobe predominant group, they again divided them into low exercise capacity and high exercise capacity. The only group that had a mortality benefit were those with upper lobe predominant emphysema and low exercise capacity. When we look at exercise capacity and health-related quality of life, again, in the patients, in all comers, those who underwent surgery did notice an improvement in quality of life. However, the improvement in exercise capacity was variable. When they again looked at the same subgroups, upper lobe predominant emphysema versus non-upper lobe predominant emphysema, those with upper lobe predominant emphysema had an improvement in exercise capacity as well as quality of life. So to summarize this trial, which was a negative trial, so a negative surgical trial, lung volume reduction surgery improved survival compared to medical management in a very specific patient population. This not only impacted recruitment into the study, but it also limits referrals, and the amount of lung volume reduction surgery that's being done has gone down after this trial was concluded. Also, when we look at economic analysis, lung volume reduction is more costly compared to medical management. And because of this NET trial, we have started to investigate other interventional options with our bronchoscopes to help patients with COPD feel better, live longer, and have improved exercise capacity. So I'll turn that over to Dr. Berkowitz.
Thank you, Carrie, and thank you all for coming. As Dr. Yodo mentioned, Keriann was one of our fellows here in our interventional pulmonary program, and I think it's the most impressive part of her talk is that she waited until the last minute before the word bronchoscope was used. Mm-hmm. That's very, very difficult for an interventionalist to do, and I know talking about COPD was very difficult without mentioning bronchoscopy once, so I really do appreciate her overview. But for a second, let's think about what a crazy idea lung volume reduction surgery is, right? This is taking the sickest of the sick end-stage COPD patients, the patients we see in pulmonary clinic, to get surgical clearance for a cataract removal. And we all sit there and say, will this patient actually tolerate it? And now we're saying, well, not only are we going to put them to sleep under general anesthesia, but we're going to open up the chest, do a median sternotomy, take out diseased pieces of both lungs, and then hope for the best afterwards, saying that this is going to improve lung function. So the concept of lung volume reduction surgery in itself is kind of a novel idea. I think the NET trial did show us that there are some patients that are definitely going to benefit from it, and there's mortality to it, there's quality of life. But what I'd like to focus in on the alternatives to this, we can achieve the same results with less of the morbidity and mortality, and that's through bronchoscopic LVRS. And I'll start off by saying the LVRS, bronchoscopic LVRS, this isn't surgery, so this is somewhat of a misnomer. There's really no S. It should really be LVR. but it just doesn't sound the same, right? So LVRS is what people know. So these are different types of bronchoscopic therapies used to collapse part of the emphysematous lung without having to do surgery. And I hope by the end of this, I'll convince you that we get the same results with less morbidity. So the principle here is not surgical removal of the disease, the emphysematous lung, but collapse of that lung tissue and redirection of the airflow to the healthier lung. So the diseased lung collapse, it's not actually removed. The healthier lung expands. So this decreases hyperinflation, overall improves better VQ match, and overall lung function improves as well. And we'll look at some of the objective data here in just a second. So what are the advantages? The advantages are that this is a much less invasive procedure. It can be done in 30 to 45 minutes typically. It could be done as an outpatient procedure. There's no incisions, can be done under moderate sedation and or general anesthesia. There's a quicker recovery time. And given that there's less morbidity associated with it, we may actually see, and I'm not saying that we have the data yet, but we may see that we can expand some of the criteria of which patients would actually qualify as compared to the strict criteria and all of those exclusions we saw for the NET trial. The data hasn't been looked at yet, or I should say the study hasn't been looked at yet, but theoretically it's more cost effective, and in some cases this is reversible. I know not all of us are Dr. Van Nostrand, who does 1,000 bronchoscopies a year. So just as a review of what a bronchoscopy is, this is a small flexible camera, goes in through the airway past the vocal cords. It's about 5 millimeters in diameter. The working channel is 2 millimeters or less, and that's what all the equipment for interventional procedures, including the valve placement and the other techniques we will look at for bronchoscopic LVRS, has to fit through. So everything is in a very tiny space. So the first stab, excuse the pun, at LVRS, bronchoscopic LVRS, was the EASE trial, and Emory was one of the sites for the EASE trial. So the concept here is that the bronchoscope goes in through the normal air passages and makes a hole using a needle, a transbronchial needle, into the emphysematous lung tissue. And then once that hole is created, a stent was placed. This was a stainless steel stent covered with silicone, which was drug-eluting. You know, they hit all of the check boxes for a new technique, a new technology here. And what this did is the theory was to allow some of the air coming out of the emphysematous lung have a passage into the bronchi and then be exhaled. This is what one of the stents look like. There were a number of problems with this study. It was considered a negative study in that there was no benefit in terms of quality of life, so the dyspnea scores didn't improve. There was an improvement in the degree of hyperinflation, so residual volume went down and the FEV went up when patients were tested the day after this procedure was done, but this didn't persist for 3, 6, or 12 months. So there was no objective improvement in lung function. This was also extremely challenging to perform. As you can imagine, placing a needle through and creating an artificial air passage when there is all sorts of pulmonary, arterial, and venous circulation around was very challenging, and the procedure took in the order of almost 2 hours, so approaching that of a surgical lung volume reduction. So that's the EASE trial was considered a failed attempt at bronchoscopic lung volume reduction. This was followed by the Spire trial, which Emory was also a site for. This was a gel foam sealant, which was instilled through a catheter in the working channel of the bronchoscope. And this was a synthetic polymer, which when it was in the airway, created like a foam, kind of like, think about like the foam sealant you use, like the tough stuff you use at home to seal around windows and doors. So this filled up the airway and created collapse of the lung tissue. There were a few problems with this study. This was irreversible, okay, which I would say in some cases could be problematic because it occluded the airways and all of the parenchymal tissue. It was difficult to diagnose infiltrates, so like post-procedural infections like pneumonia. You couldn't see nodules. You couldn't follow nodules, which were growing. The product itself was pulled from the market because the trial ended abruptly. There were administrative and economic reasons for that, but this foam sealant is no longer manufactured. A third attempt was a thermal vapor. This was called the STEP-UP trial, and a lot of these trials were working in parallel. The STEP-UP trial was a way of creating scarring in the airways, in the small subsegmental airways of respiratory bronchioles, using very high temperature steam. So it was a vapor that was instilled into small airways and caused scarring. So this, think of like smoke inhalation, that sort of type picture. This trial actually had some beneficial results. One of the downsides to the trials, this was not performed in the U.S., so this is not an FDA-approved technique right now. There is irreversibility to it, so the same problems that we saw with the gel foam sealant occurred in this trial as well. And since a lot of these trials, these bronchoscopic lung volume reduction surgery trials, are working parallel, this trial was a little bit later off the bat, so a lot of the patients that screened out because they had collateral ventilation, and we'll talk about this concept in a second, were placed into this trial. So it was a very selected patient population, and we select out patients that don't have collateral ventilation. So this is not some of the patients that normally would be referred for LVRS, but we'll talk about some of this in a second. But again, this is not available in the U.S. The final trial I wanted to mention prior to looking at the valves, which we'll spend a majority of the talk today discussing, is these lung volume reduction coils. And this is very interesting. These are nitinol coils that have this predetermined shape you can see at the bottom of the screen here. When they're implanted through the bronchoscope, they come in a long, straightened form. And then as soon as they're implanted into the airway, they assume this shape. And as they curl into the shape, they're grabbing some of the lung tissue with it, and it retracts it inward. So it sounds like a crazy idea. I mean, I don't know if it's any crazier than the concept of lung volume reduction surgery itself, but these actually tend to work. The trials haven't been performed in the U.S. The data looks very similar to the valve data, which we're going to review, so we're not going to specifically look at the data with these at this point, but the results would be very similar to the endobronchial valves, which we're going to look at. The benefit to this is that these can be performed bilaterally. They're about 10 coils per procedure. They can be performed bilateral, and they can also be performed in patients who have more homogeneous emphysema with collateral ventilation. So this probably adds a benefit over the endobronchial valves. So I do want to spend kind of the remaining time here discussing endobronchial valves, and the reason for that is that these are the ones that have been recently approved by the FDA for bronchoscopic lung volume reduction. The way the valves work is they create unidirectional flow, so during inspiration, the valves prevent airflow from going past the valve itself into the smaller airways in the parenchyma. And then during exhalation, they allow for unidirectional flow, so the air decompresses from that area of emphysematous lungs. So during exhalation, it decompresses and then doesn't reinflate during inspiration. So all of that lung tissue eventually collapses distal to where the valve is placed. These can be placed bronchoscopically, and the two forms we're going to look at are both the self-expanding metal stents, and they can come in various sizes, so we can occlude airways from the subsegmental level all the way up to the lobar bronchi. They can be placed under moderate sedation, although most of the cases now are being done under general anesthesia. So these are the two valves. The one on your left is the Zephyr Valve. This is a duckbill type valve, which during inspiration, the end of the valve is closed, and then during exhalation, it opens up. So it's closed during inspiration, so that air is not going towards the lung tissue itself, but during exhalation, it opens up and decompresses airflow from that emphysematous diseased lung tissue. These were recently FDA approved in June of last year, and they have recently become commercially available. The spiration valve, on the other hand, is this umbrella-shaped valve that's made out of a nitinol backbone, and then there is a polymer which prevents airflow from going past it. So we'll see what it looks like in just a second, but the valve is sitting in the airway. Air kind of hits the top of that cup, the underside of the umbrella, and can't get past it. But during exhalation, the airway dilates up enough that airflow can get around the valve. And the reason the valve doesn't move is it's got these 5 feet that are implanted in the distal airway. So it's held in place very well. The way these two valves came to market are somewhat a different story. The Zephyr valve was, with the duckbill-shaped valve, was a valve used in multiple of the studies we're going to review here in just a minute. And there was a lot of push to getting the valve out there for this one indication, the lung volume reduction surgery. The spiration valve, on the other hand, had an initial negative beneficial trial and then went through a circuitous route to getting approved. So they were approved, the spiration valves were approved for humanitarian use for bronchopleural fistulas after thoracic surgery. So those patients that had a lobectomy and had a persistent air leak, you could put the valves in and stop the air leak. So they were approved, at least conditionally, for this one indication. And they weren't studied for LVRS until a trial that's about to be published, but data was presented late in 2018. But because of the data from this one trial and the data we have from the Zephyr trial, or the Zephyr trials, I should say, the FDA approved the spiration valve in December of last year, so that's only about 3 months old. This is what the valve looks like in the airway itself. Both of the valves are placed through a bronchoscope, through the working channel. So there's a catheter that the valve is compressed into the catheter itself. The catheter is pushed out into the target airway, and then the valve is deployed. So these are, wrapped down to less than 2 millimeters. The initial study looking at bronchoscopic endobronchial valves for bronchoscopic LVRS was the VENT trial, which was published in 2010 in the New England Journal. This, again, was the Zephyr valve. Most of the data comes from that particular product. There were about 300 patients, and I'm going to just overview kind of what these patients look like because they're almost identical in all of the trials. But they were very, very sick, a very severe COPD with an FEV1 of less than 1 liter and about 30% predicted. And the Zephyr valves were placed through bronchoscopy in a single lobe, and about 3/4 of these patients had them under moderate sedation. And the duration of the procedure is roughly 30 minutes. And again, this is fairly consistent across all of the trials, especially the number of the average valves per patient. It takes about 3 to 4 valves per patient to completely occlude a lobar. A lobe, essentially. This is what the valve looks like in place. So again, on your left side during exhalation, the duckbill opens up, air decompresses, and then the image on the right is during inspiration where it's completely closed so no airflow can go to that part of the lung. So a very similar kind of situation as what happened with the NET trial happened with the VENT trial. There was a big rush to look at the data from these patients, and even though there was a net benefit in the FEV1 6-minute walk and the St. George Respiratory Questionnaire, so your quality of life questionnaire, these results weren't very robust. So even though there is a benefit, and you'll see there's a benefit across most of these trials in terms of an objective side, so the FEV1 isn't improving, there's a 6-minute walk improvement, and patients feel better. It wasn't until you start looking at the subgroup analysis which patients benefit the most. So when you break it down, just like in the NET trial, those patients that have a high degree of heterogeneity of their emphysema benefited way more than patients that have a low heterogeneity, which intuitively makes sense, right? If you're going to only occlude one lobe of the lung, you want a lobe that's very diseased rather than having multiple diseased lobes of the lung. So that makes sense. The one thing that they didn't account for, which I think they were a little surprised about, was this concept of a complete fissure, so collateral ventilation. And you see there's a very big difference between the percent improvement in the FEV1 when you account for the fissure completeness. So what does a complete fissure mean? So a complete fissure is when there's complete separation between two lobes of the lung. So the visceral pleura is coated on say the left upper lobe, left lower lobe, and there's complete separation between those two lobes of the lung. If there's not complete separation, you can have what's called collateral ventilation. Collateral ventilation is when there's ventilation of the lung parenchyma, not through the normal passages. So normally air is getting to the lung parenchyma, going through the central airways, following the respiratory tree down to the alveoli. However, if there's collateral ventilation, if there's incomplete fissures, some of the airflow can bypass that usual mechanism and go through the fissure itself. And this is an important concept because this would explain why some patients benefited more than other patients when you perform bronchoscopic LVRS. So a complete fissure is going to be a good patient to consider for endoscopic or bronchoscopic LVRS or valve placement. And a complete fissure, again, is felt to indicate that there's little to no collateral ventilation, so that if you occlude that area of the lung, it's going to stay collapsed. However, if there is an incomplete fissure, you put a valve in place, that area can reinflate by bypassing the normal mechanisms of ventilation. So nothing is accomplished by placing a valve or occluding that airway. Just to emphasize this point one last time, this is a diagram showing a balloon, a bronchoscope and an endobronchial balloon occluding the left lower lobe. And with it occluded, you can see that if there is an incomplete fissure or collateral ventilation, the lobe won't stay deflated because there's airflow through the left upper lobe bronchus. Okay, so this is an important concept which they accounted for in the next Zephyr Valve trial, which was the STELVIO trial, which was also published in the New England Journal of Medicine about 5 years later. It's a smaller study. This was only 70 patients, and again, this was a non-US based study. This was in the Netherlands. One of the criticisms of the initial valve trial was that there wasn't enough follow-up, so this was published after 6 months of follow-up. These, again, were the Zephyr valves, and in this trial, the main difference to the event trial was that they accounted for collateral ventilation. And the way this was done, this was performed using a proprietary system that the company that makes the valve created. It's a Chartis system. The way this works is that the bronchoscope goes into a lobar bronchus, one of the target airways, and a balloon is inflated. At the end of the balloon, there's a sensor which measures airflow, and that's what you see in the bottom left corner there. Those orange bars are measuring airflow by the sensor when the balloon is inflated. So if the flow is decreasing over time, there's no collateral ventilation, meaning there's a complete fissure, and this is a patient that would be appropriate for randomization into valves versus the control group in this study. Now, a patient that looks like this, where there's no decrease in airflow over time, the orange bars are staying kind of at the same level, means that even with the balloon up, that lobe is staying inflated. So there is collateral ventilation, and this was a patient that would screen out for the trial. So they would wake up and they'd go home after the procedure. Again, the results of most of these studies kind of have the same theme that you will see. There's an improvement in FEV1 in valve-treated patients. There's an improvement in 6-minute walk distance, and this is actually a pretty robust improvement. It increased about 60 meters, which minimal clinical significance is about 24 to 25 meters. And then the same thing with the respiratory questionnaire. A mean clinical significant improvement is about -5, and they were -21 in the valve-treated group. There was improvement in the control group as well for placebo. The complications here, however, were a little bit more severe than in the VENT study, the study 5 years ago, or 5 years prior to this. About 18% of them had a pneumothorax in the valve-treated group, and there was a 12% rate of COPD exacerbations. And although I think there were approximately 40 patients that were randomized to actually being treated with the valve, 8 of them had to have their valve either temporarily or permanently removed, mainly because of the pneumothorax rate. So the conclusions on the study is that the pre-selected patients, so those patients who did not have collateral ventilation, had improvement in FEV1, 6-minute walk, and quality of life scores with the valve treatment. But you have to select the right patients because there are potentially life-threatening events. So fast forward to a couple months ago in 2018, the LIBERATE trial was published. This was a much bigger trial, almost 200 patients, and this again was, or I should say initially, was the largest trial based here in the US. There was a 2-to-1 randomization to valves versus no valves, and they accounted for collateral ventilation in this study as well. They used the Chartist system again. They did follow up for 12 months as opposed to 6 months in the last 2 trials. And then at the end of the 12 months, patients who were in the control group who didn't have the valves then had the option of undergoing valve placement. So the methods here are a little unique for a clinical trial, and I want to spend just a minute here discussing them. So in this trial, the LIBERATE trial, the Chartist system was performed to determine whether collateral ventilation was occurring or not. If there was no collateral ventilation and patients screened in, they were then randomized again 2-to-1 to valves versus no valves. So in patients that were randomized to control group, they still performed a bronchoscopy, a sham bronchoscopy, for the next 15 to 20 minutes, whatever the average time for the valve placement on top of the Chartist was. The patients who were in the control group were then discharged to home. However, the patients who underwent valve placement were then hospitalized per protocol because of this rate of pneumothoraces in the prior study. So there were enough life-threatening events that as part of the protocol, these patients were hospitalized. It says 5 days, but it was anywhere from 3 to 5 days, underwent daily chest x-rays, plus had a chest tube kit at bedside. So people were very concerned about this, the rate of pneumothoraces. Even after discharge, patients were contacted every day to make sure they weren't having symptoms that would be suggestive of a pneumothorax or a serious life-threatening event. And then over the next 6 weeks, they were followed up in person on 3 different visits. As per protocol, a one-time valve adjustment was allowed, and as seen in prior studies, there were about 4 valves placed in each lobe. So the primary outcome, the primary result they were looking for was the percentage of subjects who had a change of FEV1 greater than 15%, which is considered clinically significant. You can see 48% of them had an improvement in the FEV1 greater than 15%. Secondary outcomes very similar to what we've seen in some of these other studies. The FEV1 improved, the 6-minute walk distance improved, whereas actually declined in the control group. And the St. George Respiratory Questionnaire scores decline, which indicates less dyspnea per patient. This is a nomogram of the adverse events of the pneumothoraces. So this is kind of distribution of when pneumothoraces occurred. The overall pneumothorax rate was 26%, so comparable to other studies. 3/4 of them occurred within the first 3 days. And if you look at the day 0, so that dark blue area showing 5 patients actually had their valve removed on day 0 because they had symptomatic pneumothoraces. And then over the first 5 days, 85% of the pneumothoraces that were seen, of all the pneumothoraces, 85% of them were seen in the first 5 days, which is why they were hospitalized per protocol. The one comment that they did make at the end of the study is that the pneumothorax overall did not seem to significantly influence long-term outcomes in the study. And I think I know where they were hinting at, and we'll talk about that in just a second. I do want to quickly run through the only trial that we have of the Spiration valve. And I want to mention this because the Spiration valve has been FDA approved for the last couple of years for a different indication. These are the ones we have most experience with at Emory. And when we start doing bronchoscopic lung volume reductions, these are probably the valves we're going to be using. This is the EMPROVE study, and this was, again, this manuscript has yet to be published, but this data was presented at an international meeting recently, which was what led to the FDA approval. About 174 patients randomized 2-to-1 again to valve to control. Patients had pulmonary rehab just as they had in all of these other trials, and there was 12 months of follow-up. Again, baseline characteristics look very similar to all of these other trials here. Again, this is what the Spiration valve looks like when it's implanted. So it's an umbrella which catches air during inspiration, preventing it to go to the distal airways. And then during exhalation, the airway actually dilates around the valve so that air can escape, and then that kind of passageway closes up. In this picture here, you see that secretions also can go around the valve, and I think that's one benefit these valves have over the Zephyr valves is there's better mucus clearance, which you can imagine in end-stage COPD patients can be significant. So just like in the Zephyr valves, there has to be a way to account for collateral ventilation. And because the Chartis system is proprietary to the other valve, they had to come up, Spiration had to come up with a different way of measuring collateral ventilation. And they used a artificial intelligence kind of 3D modeling system of a CT scan. And it's this proprietary called Select or CELI-CT. Which will, again, 3D render a high-resolution CT scan and determine how much fissure completeness there is. And I know it's hard to see in this diagram, but in the left lung, you see that there's a solid line, which means there's greater 90% fissure integrity, meaning that there's 90% complete fissure in the left side. Whereas on the right side, the major fissure is kind of a dotted line, and that says that fissure is not complete, so there's a chance for collateral ventilation. And then it measures the emphysema severity in that lobe and the heterogeneity, right? Those are the things that we had to look at according to subgroup analysis from that original trial. And when you have a full green circle there, that means that's a lobe that can be targeted and the patient would benefit from valve placement. And as part of this trial, again, about 4 valves were placed per lobe, and the procedure time was under 30 minutes. Primary endpoint, again, change in FEV1, so very similar to the last trial, the LIBERATE trial, which was a 48%. This is 37%. Improvement in FEV1 and the responder rate of greater than 15% improvement in the FEV1. The 6-minute walk difference didn't improve much in this study, but the quality of life scores were significantly different than the control group. This is an example of what that CELI-CT, that 3D rendering of the lungs look like. So this is a patient that on your left side is pre-treated hyperinflated left upper lobe. So the software determines that the volume of that left upper lobe is 1.8 liters. And then after valve placement, the post-treatment is on the right side, and you can see the green, which is the left upper lobe, has shrunk considerably, and the left lower lobe has expanded. So that the post-treatment, average post-treatment decreased by about 1 liter. So I'm sorry, those are averages, not for this patient specific, but the averages went from 1.8 liters to 0.8 liters. So it was an overall 53% reduction in the target lobe with the valve placement. The only statistically significant difference in complication rate was for pneumothoraces, and this was a little bit lower than in the Zephyr Valve trials. And then there was one probable device-related death from a lung abscess, which occurred in a valve-treated lobe. This was in the 6 to 12-month follow-up period, but those are the major complications. So I think it's worthwhile spending a minute discussing what pneumothoraces mean in these patient population, because this is always listed as a complication, and it's concerning enough that patients in at least one study were admitted and observed for the pneumothorax. So clearly pneumothoraces in patients with limited lung function can be life-threatening, but it's not life-threatening in all of the patients. And I think if you look at the pneumothorax rate in the first 3 trials, which did not account for fissure completeness and collateral ventilation, you can see that the pneumothorax rate is a lot lower. So these patients weren't developing pneumothoraces as much because the lungs were staying inflated. So what this tells me is once we start looking at collateral ventilation at fissure completeness and accounting for that, we're getting better responders. We're finding the right patients to treat, but the lungs aren't inflating. So that's why we're seeing the pneumothoraces. So are the pneumothoraces procedure-related complications, or in some patients is that our target because the lung won't expand? So the analogy here is to a trapped lung, right? So a trapped lung means that there's a pleural fusion, you drain the fusion, the lung doesn't expand. The same thing is occurring in these patients because these lungs were hyperinflated. We put valves in and we're preventing the lungs from expanding. So I would argue some of the pneumothoraces are expected, and some of the pneumothoraces we're seeing are actually because we're choosing the right patients that don't have collateral ventilation. Now, that's not the case for all the patients, and clearly, as I mentioned at the offset, there are some patients with limited lung function and pneumothorax could be life-threatening. But there are some patients that we actually want to see that the lung isn't fully expanding, that the lung has collapsed and hasn't fully expanded to fill that space. There is a difference. The last trial, the EMPROVE trial, which is to be published, is a different valve. The pneumothorax rate's a little bit lower in that one study, and that may have something to do with the valves. I think those valves are a little bit different design than the Zephyr valves. And that may indicate that what we see in clinical practice, the pneumothorax rate is going to be a lot lower than the high 20s that we see in these other trials. And then to kind of round things out here, in conclusion, the point that I was hoping to convince you of is that if there are a subset of patients that would benefit from lung volume reduction surgery because they meet certain criteria, but they are not being referred for this procedure because of their morbidity and their mortality associated with it, can we achieve the same results with bronchoscopic LVRS? And if we look at the data which has been published, we see that objectively the FEV1 is very similar in the endobronchial valve trials. The 6-minute walk difference varies considerably, but can be comparable to the best case scenario, the subgroups that benefited the most in the NET trial. Patients clinically feel better with improved quality of life scores, but the complication rate is less. So in the NET trial, all patients were hospitalized after lung volume reduction surgery, and at 30 days, 28% of them were still hospitalized. Even with the 5-day hospital admission to monitor for pneumothoraces, I would argue that we're doing better off in terms of postoperative complications. Pneumothorax, we discussed just a second ago, almost everyone after an LVRS either had an air leak, some sort of pneumothorax as that space, as the lung expanded to fill that space. Endobronchial valves are a reversible way of achieving the same results, and this might be something that would be important in, say, candidates that are also being considered for lung transplant in the future. In some of the studies, the valves were removed and or replaced so that there is revision or retreatment with some of the valve placement, and the mortality and 90-day mortality is better in the right patient population. So to kind of complete the recommendations here, this was the gold, kind of the dyspnea Bible that recently was published earlier this year. And I was just curious to see what sort of conclusion the gold and recommendations gold makes for bronchoscopic LVRS. And just to read it, a comparison of the treatment benefits and complications associated with endobronchial valve placement compared to LVRS demonstrates the comparable benefits from the valve with fewer complications. And I think that's kind of where we're going with this new novel treatment. So the ideal patient that we would see for bronchoscopic LVRS for valve placement would be someone with heterogeneous emphysema, so that one lobe, when treated, would give you the best bang for the buck, the most results. Patients who have complete fissures and no collateral ventilation. And then these are literally the same demographics, the same inclusion patients from the NET trial. So age less than 75, FEV1 kind of in that sweet spot where it's not too severe, so greater than 20% predicted, but less than 45%, but evidence of hyperinflation and air trapping with a DLCO greater than 20%. So patients that would tolerate moderate sedation bronchoscopy, and the potential for pneumothorax. And that is all I have, and I'm happy to take any questions. And thanks, everyone, for their attention.
Any questions from the audience here first? Dr. Morris.
It appears to me, particularly when you look at the lung.
Wait, we're going to get you a microphone so that they can hear you at the other sites. I know you have a booming baritone, but it doesn't carry without a microphone. Hello? Oh. Is it? While he's doing that, can I ask quickly, do you require that your patients be non-smokers when they come in for this procedure?
That's a good question. I think that would be, since there's as much of a benefit to smoking cessation as there would from a intervention, I think that would be something we definitely would require, absolutely.
My question was more of trying to measure how much lung volume you're removing. It looks to me like it'd be very primitive, but I might be mistaken in trying to decide, are you removing too much, you're not removing enough? Is there a way to do that?
Yeah, it's a good question. So in the NET trial, it was about 25 to 30% of the lung removed. With the recent EMPOWER trial that had that modeling of the 3D reconstructions, it was about a 53% reduction of the target lobe. So if we were to say that try to apply that to bilateral or at least unilateral on the same, so if it's two lobes at the left upper lobe and it's about 53% decrease, I would assume that would be about equivalent to what would be in the NET trial, so also about 25% of the lung, of the ipsilateral lung. But there's no way of knowing for sure.
We're going to start seeing a lot of these butterflies in the chest X-ray.
Potentially, yeah. Interestingly, we've probably placed maybe 24 or so of these for the indication of persistent bronchopleural fistula. You barely can see them. Sometimes you're searching to look for them because they're literally a couple millimeters in length. But yes, I think that we probably would be, especially in the CT scans. They come out much easier. Can see them much easier.
Thank you for sharing this with us. It seems like it is a very well-tolerated procedure apart from the pneumothoraces in an otherwise very fragile group of patients. So for the patients who suffer a pneumothorax, would you consider repeating the procedure at a later date? Or do you feel like some of the data that you presented about how this is a very different population and it's not exactly pneumothoraces would mean that this is just not a procedure that they would be able to tolerate?
I think that depends on clinically how patients are doing with the pneumothorax, so how well they tolerate it. So again, a patient who has a trapped lung, so they have 3-liter pleural effusion and you drain out a majority of it and their lung doesn't expand, they still feel relief of dyspnea. So in that situation, the trapped lung we don't treat, and I would say in some of the patients, and again, we don't have a lot of the experience because this is a really relatively new procedure. I think people were overreacting in some situations just because you don't have a lot of time in someone with marginal lung function if they do develop dyspnea and the x-ray shows a pneumothorax, and you see the pneumothorax rate was the highest on day 0. And the most valves that were removed in the LIBERATE trial were at the same time of placement. So it was also on day 0. So I think people reacted very quickly. And as we gain more experience, we will be able to know if we can take these valves out, put them in a different lobe, is the same result going to occur? Or are some of these pneumothoraces the ones that you repeat with x-rays every 3 to 6 hours just to see if it's increasing? Because I would argue if patients wake up and they feel better, I don't care how big the pneumothorax is as long as it's not changing.
Are there any questions from other sites? So since we have a minute, if I could follow up on Karen's question. This is not the usual pneumothorax. This is not a ruptured bleb. This is not a needle going through the parietal and visceral pleura, in which correct me if I'm wrong, because I've been a pulmonologist for a long time, but I've never done this. You're decompressing the upper lobe, and you're asking the lower lobe, for example, on the left, to basically kind of crawl up and herniate into that space. And that might not happen like that. So do we really need to rush in the first few hours with a chest tube? Could that patient be given high percentage of oxygen, because that nitrogen's got to get out of there and it's going to take a little while? So to your point, should we be just monitoring the pneumothorax because it's predictable, and if you give that lower lobe time, it may eventually herniate up into that space?
Yeah, that's a great description. Much better in the way I could describe it. But yeah, absolutely. These are not the garden variety pneumothoraces that patient comes in with pleuritic chest pain, their lung is collapsed because of an external injury. This is a post-surgical, so to speak, pneumothorax where, you can gradually see over time the lung expands to fill that space. But I think that pneumothoraces in the right patients are going to be expected, because if you're occluding the lobe, as Dr. Godo mentioned, it's going to take time for the remaining lung tissue to expand and fill that space. It can't happen instantly. So it'll be interesting to see kind of in clinical practice what that looks like. But I definitely feel like these are patients that there's going to be a lot of close observation for multiple reasons. I think one of the studies, the study where the patients were hospitalized for 5 days, were on the right track. These patients do need to be observed, because going home when you're 30 years old and having a pneumothorax at home is going to be different than when you're 70 years old and you have an FEV1 of 0.8. It's going to be, there's a lot less time to respond in those situations.
All right, well, thank you both of you for that.